But I'm Michael Hebb and the founder of Death Over Dinner and EOL.community. And we're here for our weekly session with Dr. Jim deMaine. And welcome back, Jim. We're going to be talking about ethics today.
Thank you, Michael, and welcome back from your wonderful trip you took down the Middle Fork of the Salmon. Nice to see you in one piece and nice and relaxed. It's great. Yeah, I'd like to talk about medical ethics and kind of how that is a relatively recent application in medicine. I mean, ethics have always been discussed from the time of Hippocrates and the do no harm principle, but it didn't have much direct application in medicine. In fact, medicine was quite paternalistic until at least the 1960s. And what happened in the 1960s was really the result of one physician named Belding Scribner, who was a professor and kidney specialist at the University of Washington. And at that time, it was possible to do dialysis on a patient, but just one time. The glass tubes that were used in the blood vessels caused damage to the blood vessels, and it could only be done once. And yet it had remarkable improvement for the patient for that very short period. But Scribner thought about it, and one time an idea came to him to develop a Teflon type shunt that he could put in an artery in the vein, and the blood would flow through that. But you could disconnect it outside the body, disconnect that shunt, and put that blood through a machine, which would functionally behave like the kidney and get rid of waste and reestablish your electrolyte balance. So suddenly that seemed like a great thing to do, but then there was this pent-up demand of patients that wanted dialysis. Scribner rapidly developed Northwest Kidney Center, could handle up to 17 patients, but the demand was overwhelming, and they had to choose who was going to get dialysis and who didn't. And they decided to form a committee, which was a community ethics committee, but it was dubbed the Seattle God Squad or Seattle God Committee because they were making life and death decisions as to who to choose. And they chose community people to be on this committee: lawyer, banker, housewife, government official, labor leader, surgeon. And they used various criteria, which would seem very old-fashioned and paternalistic now, if you look at their deliberations. But that was really the start of, when we have scarce resources, how are you going to decide who gets those resources? What criteria are you going to use? And of course, American medicine, anyway, what we do is we tend to expand the resources. And very rapidly, we expanded the kidney machines. And then in 1973, kidney dialysis was covered by Medicare, including all supplies. It was really a disease of socialized medicine, if you will, because no matter what age you were, if you needed kidney dialysis, it was covered. And that didn't seem to be terribly costly at the time, but now, of course, it's grown from 11,000 patients up to 527,000 people are receiving dialysis at a cost of $23 billion. So it's phenomenally expensive, but yet it's something that we've decided to take on as a society as a whole. But the idea of ethics committee began to catch on because it wasn't just allocation of scarce resources. A lot of it was on end-of-life treatment, people on ventilators or people near the end of life, what treatment should be applied. And gradually, hospitals began developing committees, and now basically all the approved hospitals have ethics consultants or ethics committees. So actually, if you're ever in a hospital and you're in a dilemma with the providers, ask for an ethics committee review and consultation. they aren't the final word, but they are a very strong voice, and have considerable weight um, if it goes to the courts or just among the people trying to achieve a decision. And they try to use historic principles in ethics. A very strong one in American medicine is autonomy. The individual should have a right to choose. We can have informed consent. We can decide what's going to be done to our body or not done to our body. So autonomy, at least in American medicine, takes precedence most of the time. I'll present a case that's not. The other is principle is beneficence, which really means that the medical provider is trying to do the best they can. It really means doing well. But sometimes what the provider feels is doing the right thing and what the patient wants will differ. And that's where conflict arises, and that's where deliberations and ethics committees can sometimes be benefit. And another ethical principle, of course, is do no harm. It's the old principle, first principle in medicine. You can do harm by doing something to somebody, or you can do harm by not doing something to somebody. So it's a general principle where we want to avoid any intentional or unintentional harm. But that's kind of the background. But what I'd like to do is talk about a couple of stories from my book. And one is a fellow in his 40s that came into our hospital. His name is Dan. He was brought in emergently. Turns out that his wife did some home canning of spinach and had not done it properly. And in that situation, the botulism organisms can grow and produce toxin in the canned product. And fortunately, Dan was the only one in this product that tasted it, that had spinach that evening. The kids, the two young kids did not like spinach, so it was not a choice. And for some reason or other, his wife did not have it that night. So what he noticed was drooping of his eyelids, sagging of his face, the arms became quite weak, and then he began having trouble breathing. His wife called 911. They saw him, noticed he could not keep up adequate respiration. And so they intubated him, that is, they put a tube down through his mouth into the airway and breathed him manually using a bag and supplemental oxygen, and transported him directly to our intensive care unit, where I became the attending. And the care there is mainly supportive. We did obtain some antitoxin from the CDC and gave it to him, but that didn't seem to have any effect. So we knew from the literature it was going to take a month or two for Dan to recover. And we kept him on a ventilator, actually did a tracheotomy so he could breathe comfortably through that. We put a feeding tube in so we could give him nutrition. The main thing was to prevent infection or bed sores, and also to try to support him emotionally, where when you're in the intensive care unit in a situation like that, your whole world shrinks into your room or into your bed or into your discomfort, and you lose track of time and place and ability to think or reason. But at about a month, Dan was still very weak, and he was able, though, to begin to communicate with us with a writing board, or even whispering some for brief periods off the ventilator, that he wanted to be removed from the ventilator. He said, "This is miserable. I want to die. Please let me die. This is just horrible." And of course, that shocked his wife. She wanted her husband back. She knew his outlook was good. The mortality rate for good care in botulism is only 5 to 10%. So he had a very good outlook. And of course, the children that they could voice, they wanted their dad around. And the nursing staff and I all felt that, we should push ahead. But he kept asking. So I had a psychiatrist sit down, and psychiatrist said he wasn't clinically depressed and he was rational, but he could not see the future. He couldn't see beyond the present. His whole world has shrunk into where he was trapped. So that didn't really help us too much. We took it to our ethics committee, and the ethics committee struggled with this, but although we felt Dan had the autonomy to speak for himself, we just all intrinsically felt he was not speaking wisely for himself. So we became paternalistic in a sense, and we kept the ventilator going. I wish we were in a situation where those listening in today could vote on what they would do or what they would want done. But we did keep Dan going, and eventually he uneventfully was able to be weaned off the respirator. Everything healed up normally with rehab. He regained all his strength, was able to return to family life, work, and basically a normal life. But it was interesting when I saw him back in the office a few months later. I said, Dan, how do you feel about all this? Because we really didn't listen to you at the time. And he said, well, Dr. deMaine, I'm really happy to be alive. I can't argue. My wife, my kids, my job. But he said, part of me is still really pissed off at you guys that you didn't listen to me. So he was conflicted. And there's situations now, there's a famous legal case of a fellow who was in an industrial explosion, and he lost both his hands and he lost his sight, and he was terribly disfigured. He was in a burn unit for months, had very, very painful treatments, very prolonged, but he survived. And he actually went on to law school from there and became an advocate for what we call the right to die. He was involved in situations similar to Dan's, where he would be a strong advocate for being somebody being allowed to die. So this is where the ethical principles can conflict, the autonomy on one side and beneficence on another. I'd like to, if I can, go on with another story that just shows the converse. This is a fellow, again, I met urgently in the intensive care unit. He was 65 years old, climbing a ladder up on the second story of his house to get leaves out of the gutter. And it was kind of a rainy day, but he anchored the ladder and he was up there, pulling the leaves out of the gutter. And at that moment, he had a heart attack. He had crushing chest pain and actually fell backward off the ladder and hit the ground in an awkward position. And 911 was called. They came out and got him. They actually did CPR, got his heart started, and he seemed to be gaining some level of consciousness. But they noticed he couldn't move his arms and legs, and he couldn't breathe well on his own. So with neck brace and everything, they transported him to the trauma center, where it was found that his spinal cord was essentially severed at a very high level, the C1, C2, the high cervical spine level, which meant he couldn't breathe on his own. He was quadriplegic, and he would be that way indefinitely. I mean, they tried recovery, but when the spine is severed, we really don't have good ways to restore that function. But he got to our hospital and transfer. We were able to give him tube feedings, good respiratory care. He was fully alert mentally, but he just couldn't move or do anything on his own. Fortunately, his wife had very good resources, and they set up kind of an elaborate rehab program for him. It was much like Christopher Reeves, who had his accident. Remember Superman? He was in a wheelchair with a portable ventilator, a little ability to talk mechanically and move about, often using breath on a little control for the wheelchair. So you can do some elaborate things, but he was very discouraged. He said, I'm not living like the way I would ever want to live. This is not really what I would want. But his wife was insistent and very caring. They got him good physical therapy. required, total body care, massages, enemas, a lot of very unpleasant stuff to keep him going. But, they fitted their house with a ramp down to the swimming pool and put barriers around the swimming pool so he couldn't go in. And she tried to give him as normal a life or as functional life as she could. And she really, really did not want to lose him. But he kept getting respiratory infections, was in the hospital off and on. And he finally told me after about a year, he said, "This is no good. I want to be allowed to come off the respirator and die." His wife was aghast at that. And she kind of pushed him and talked him in to keep going, even though he really didn't want to, but he did it for her. And again, he had hospitalizations for infections, pneumonias, again, very uncomfortable, not the quality of life he wanted. So toward the end of the second year, we met with him again and his wife and their family members, their pastor, and he really made it clear that he did not want to go on. And about that time, the wife was again thinking about his wishes more than her wishes. And even though she was terribly reluctant to let it go, she agreed. And again, ethically, we can't force a treatment on somebody that doesn't want it. Now, the first one I presented was an exception to that. But the general rule, if somebody wants to come off the respirator and they're in the right mind, and again, it seems to make clinical sense, then we're obligated to follow their wish. So with family around, without a lot of bells and whistles or anything, we gave him heavy sedation with morphine and a sedative so that he wouldn't suffer, and we took him off the ventilator and allowed him to pass away naturally. But those are tough cases, and those are ones that you can't plan ahead for. When I was talking to Angel last week, she mentioned how there's so many nuances in end of life decisions, and sometimes rather than deciding I would want this technology or wouldn't want that technology, we really need to think in terms of the goals of care. What are your goals of care? What are your quality of life, and what do you really want? And sometimes those things only become clear after you're in the situation or when you're close to that situation. So sometimes it's hard to plan ahead for all this. So I think I'll stop there, Michael. I've probably gone on a little bit longer than I usually have, and I hope some questions are popping up from people. But
yeah, I have a couple questions. And there are some questions coming in. Everyone who's listening, you can use the Q&A functionality. There's a button at the bottom of your Zoom screen that says Q&A, and go ahead and type your questions into there. When I'm hearing you talk about it, what I hear is a lot of reactivity in the family, which is understandable.
Yeah.
We're talking about life and death and someone you love. But I think one of the reasons why people are so reactive around this, as opposed to responding to the situation, reacting to the situation, is because we aren't literate around this conversation or these topics. We don't have these conversations. And it's much like, thinking about how you were in relationship when you were in your 20s versus how you are in your 40s, 50s, 60s, 70s, and 80s. Tend to get a little less reactive to what's happening. And just curious about your thoughts on, do you see that kind of reactivity, and are there some tips when dealing with a family that is clearly reactive, or even ourselves?
Yeah, a social worker and I wrote a kind of a protocol that we suggest that medical teams use in the intensive care unit. And one of them is creating a safe space for people to talk, that's quiet, where you're not going to be interrupted by, cell phones or pagers, and that you try to find. We had a Jesuit priest that consulted with us in terms of developing this process, a guy named John Galinsky, who's just wonderfully consulted with Kaiser in Oregon for years. But he talked about forming a moral community. And we would do this by everybody introducing themselves, talking about their relationship with the individual, and then making it a safe place. So this is a safe place where you can express your opinions. It's okay. We want to hear from you. We're not going to repeat this outside the room. And it's okay to disagree. We don't have this common groupthink that we're trying to develop. We want you to feel safe to agree or disagree with recommendations. And then to make sure that all the important people are included in that conversation. If there's we call it Aunt Minnie from Minneapolis, if somebody shows up at the last minute and tries to throw a wrench into it because they haven't been included, it can disrupt everything and put everything on hold when you're trying to make a decision. Then we kind of go through a timeline of this person's life and let everybody contribute. The medical team needs to become listeners. So we back off and let them talk about, their life and how this illness began to affect them. And so everybody begins to get a clearer picture, because even as a family member, you only know portions of that person's experience. And there's some real aha moments that will come out. Then I would try to give the medical information in a timeline again about we did this, we did that. I would show x-rays or whatever people wanted to see, be very transparent and very open, and try to explain things in lay terms, not in medical speak. And then discuss the options, that we could withdraw life support, we could keep going, we could try a new therapy, etc. Then we would back away and say, well, your loved one's over there on a ventilator and they can't participate. So let's put ourselves in their shoes and say, okay, what do you think they would be saying to us? And that's very interesting, again, to go around the room. And then I would say, well, what do you really hope for? And people, they've come up with some wild stuff, let it all out. I want them back normal. I want them the way they were, whatever could come out. And then gradually try to get them back to looking at the options. And very often, once the problem is building up trust and continuity. Sometimes I would say, I had somebody just like your mom a few weeks ago, and the family was really struggling. And I would go on talking about that case and get them interested. Well, why did they do this? Or why did they make that choice? And kind of depersonalize it a little bit. So those are kind of the techniques we would use. We didn't always come to a conclusion saying, well, it looks like we have these options. Let's meet again tomorrow or whatever, but we can't force a decision. Now, sometimes in a small percentage, we end up at an impasse, and sometimes ethics committees are useful. And some hospitals where it is totally a futile situation, they allow the medical team to write a do not resuscitate order despite the wishes of the family. So you do run into those, what we call futility situations. And if anybody's really interested in the kind of the legal aspects around that, there's a wonderful blog by Thaddeus Pope. It's called the Futility Blog. And he follows all the medical legal issues around dementia directives, voluntary stopping eating and drinking, end of life decisions, medical aid in dying. He's an ethical consultant to that group. So people want to look up Thaddeus Pope, just Google Futility Blog, and it has just wonderful up-to-date articles, and he's a great ethics consultant.
Well, we've got a couple questions. Let's see if we can get through them both. First one is from Bill Newman. Given the difficult decisions you've cited, how does the ethics committee make those life and death option decisions? Consensus? How do you manage differences of opinion? And I imagine it's different via different ethics committees.
Yeah, I think, by the way, hi, Bill. Fellow physician that I haven't seen in years, I don't think. but anyway, yeah, I think the ethics committees tried to arrive at consensus, and yeah, the consensus should be transparent. When you explain it to the family. And to me, the ideal ethics committee would include lay people and a family member or two. So they can actually hear the deliberations and participate. I think a lot of ethics committees don't work that way, but in my mind, it would be great to include family in those discussions, because the more information they have, the less paranoid they're going to get. But yeah, each hospital would have its own mode. They can make a recommendation, but I think most hospitals it's not binding, but it carries considerable moral weight to the healthcare team and to the family. And so I think it's very useful.
Probably carries some legal weight too, I imagine.
I think if a decision is made where you get sued, yeah, I think that would have import for sure.
Yeah. And our MVP of Ask the Doctor, Bob Hoffman, is back with a question. First of all, he is excited about our medically assisted dying conversation, the right to die, death with dignity. Maybe we should do that next week.
We could do that next week, for
Okay.
sure.
So Bob, it's Christmas. We're going to do that topic next week. But you did have a question as well. I'm going to read Bob's question. In the example you gave, the doctor and the patient and family agreed. But if the medical practitioner and the healthcare surrogate have a different interpretation of the care to be provided to the patient based on the living will, shouldn't the surrogate have the final decision and the doctor should follow that instruction? Question mark.
Yeah, the surrogate, if they're speaking in good faith for the patient, and there I think it would probably go to an ethics committee if there was that degree of difference as to whether the surrogate was really acting in best interest, because the surrogate might be saying pull the plug when it didn't make sense, like in our young man. What if his wife was insisted that we take him off the ventilator and let him die? Would that have made any sense at all? So yeah, I think a potential roadblock is a provider disagreeing, and that's to me when that surrogate say, well, I think we need an ethics committee here.
Yeah. And really quickly, we might go slightly over, but I'm curious, what are situations where you think it does make sense to ask for the ethics committee? Obviously, you've mentioned a couple, but are there any other just kind of general situations where you want to raise your hand and ask for an ethics committee?
I think it's usually where there's disagreement between the provider and family, or the institution and family. And it's often around end of life issues. It can be sometimes cross-cultural issues, like a homeless woman being abused by her partner, but wanting to stay with her partner, and you don't know if that's a good idea or not. And they wind up in a hospital and there's mixed messages coming through, and you just need a whole lot of clarity where there's conflict, and it's a chance to have more dispassionate deliberation. In the one case I'm aware of, they felt in this woman's best interest, if she wanted to go back even to the abusive partner, that might be the best situation for her. And I found that kind of problematic myself, but some of these situations are fraught with poverty, drug abuse, alcoholism, and homelessness, that once these people wind up in a community hospital, trying to sort all that out as to the best disposition and care requires more deliberation, because the providers will disagree with each other. We aren't uniform by any means.
Yeah. So one last question, I think it's a great one, from an anonymous attendee. Could you share with us the protocol for accessing an ethics committee? if you're a patient or if you're an advocate or a family member?
I would approach the social worker or the nurse or the doctor. If you don't get a positive response from one of them, go to the next. And if that doesn't work, you can go right up the administrative ladder in the hospital. The last they want is to hear a reporter calling, why aren't you allowing an ethics committee consultation here? So they'll be responsive.
Yeah, it seems like I would almost call an ethics committee a council of elders, it seems like.
Yeah.
Yeah.
Yeah, good definition.
Perfect. Well, thank you, Jim. We have an exciting conversation, much anticipated next week. So tell all your friends. We will be talking about medically assisted dying, and many opinions and questions I'm sure will come in. So until then, have a great week. Thanks for joining us.
Thank you, everyone.